Good afternoon and welcome to today's presentation. Today we'll have a presentation on stroke. We have three guests from UF Health Shands Stroke Clinic. We have Dr. Khanna, we have Nurse Davis, and Nurse Sheehan. Let's give them a hand. Let's give them a warm welcome. Today they're going to educate us about stroke. So without any further ado, I'm going to go ahead and welcome to the stage Dr. Khanna. You're welcome. Thank you for coming.
Yeah. Okay. Hi, good afternoon, everyone. So, can you hear me? Okay. Seems like it's a little low.
Okay.
So I'm going to be talking about stroke very informally. So if you have any questions, you can. Oh, that's better. Okay. Okay. So that's too loud. Okay. Oh my God.
Try that.
Sorry about that. Okay, so if you have any questions, you can always interrupt, raise your hand, and maybe we can answer your questions actively rather than, after the presentation. Okay, so I don't have any financial disclosures. We actually all have to do that because I'm not getting paid for this, so this is, as an educational session. So these are the statistics, unfortunately but true. Each year in the United States, 795,000 people have a stroke. So a stroke occurs every 45 seconds in the US, so you can imagine by the time this lecture is over how many strokes would have occurred. Every 3 minutes, a stroke-related death occurs. Women between the ages of 45 and 54 are actually twice as likely to die from a stroke than they are from breast cancer. Stroke is now the 5th leading cause of death in the United States. We are making a difference, and we are doing things right. It used to be the 3rd leading cause of death, and now just recently, about 6 months ago, it became the 5th leading cause of death. So we are saving more lives. However, stroke remains the leading cause of disability, and unfortunately, once you have a stroke, the likelihood is after the stroke that you're not going to be completely neurologically normal and be able to return to full function and return to society. So when we say that stroke is the 5th leading cause of death, it's actually overall is the 5th leading cause of death. However, it's the 2nd leading cause of death in women. So more women die from a stroke than men. More women have more severe strokes than men. And it still is a very, very high cause of death for women. Mortality means the rate of death from stroke is highest in the areas we call the Southeast United States, and that's the area we call the stroke belt. In fact, people that live in the stroke belt are are 20% more likely to die from a stroke than they are anywhere else in the nation. And there's an area in the stroke belt we call the stroke buckle, which is the North Carolina, South Carolina, and Georgia, which the stroke rate, the death from stroke is actually 40% higher than the rest of the population in the United States. So you can see where we live, and I'll show you sort of a map. It's not portraying very well here because you can't see the colors, but all of the dark areas here, this is what we call the stroke belt. You could see it spills into the panhandle here, and the dark here, North Carolina, South Carolina, and Georgia, that's 40% higher rate of death than anywhere else in the United States. And this is sort of another picture of the red here, meaning the stroke buckle. So when we talk about stroke for each decade, so if you look here, between the ages of 45 and 54, and then going per decade all the way up to the ages of 75 to 85, your risk of stroke increases. So as you get older, no matter what you do, your risk of stroke will increase. Yes? We don't know. We don't know exactly. Genetics plays a big role. Maybe food plays some role, but we don't know exactly. So as you get older, your risk of stroke increases. And if you look here, your risk of stroke is definitely much lower between the ages of 45 and 54, and it more than doubles in the older age between 75 and 85. And why is that important? Well, it's important. These are predicted statistics for incidence of stroke, the occurrence of stroke. If you look here in the, I'm playing with this thing. If you look here, in the year 2000, under the age of 65, every year there was around 200,000 strokes. If you extrapolate that to the year 2030, the number does increase to about 229 or almost 230,000, but the increase is not tremendous. But if you look here, over the age of 65, in the year 2000, 490,000 strokes occurred yearly. But if you extrapolate that to 2030, you're looking at 882,000. So this number is actually going to double. And if you combine that for total, in the year 2000, we had about 291,000 strokes. Now we have 800,000 as of this year. But if you extrapolate that into 2030, there's going to be 1.1 million stroke incidences of stroke occurrences per year, and this is just U.S. alone. So although we are making a difference as far as people are living with their strokes, people are surviving, but more and more people are having strokes. So it's a disease that's progressively increasing, but a disease that we're able to make a difference about. Yes, there's a question. Yes. So two reasons. Yes, the population is increasing, but also the elderly population is increasing. So overall, the baby boomers, they're all getting older. They're getting into that higher risk area, age group area, but also people are living longer. People with medical conditions, not just stroke alone, we're keeping people alive longer. So your average survival for anyone is much longer. So people are staying around longer, and that's why we're having more strokes. And that's the whole thing about, it's not so much the younger population, even though that's increasing, the predominance of stroke is in that older population that's increasing and living longer. So what about costs? Well, in 2012, the cost of stroke per year is about $71 billion. Where's all that money going to? So if you look here, the largest chunk of the pie is going to be here, which is the hospital stay, nursing homes. That's where we're spending most of our money. But our second largest chunk of the pie, this blue area here, is loss of productivity. So these are people that were productive. These were people that were functioning in the environment that now can't go back to work. Loss of productivity is very important. If you look here, physician fees are only 5%, just saying. And medications, a big chunk of the pie as well, and home health services. So what do these numbers look like in 2030? So in 2012, I told you $71 billion. By 2030, we'll be spending $184 billion a year on stroke care. So not only is the rate of stroke increases, but obviously the amount of people that are living with a stroke increases. The people are living with disabilities from stroke increases. So currently there's 4 million Americans that live with disabilities from stroke. This is going to increase by 3.4 million. So we're going to have a lot more people around that are living with disabilities. And women after the age of 85 have more strokes than men, and women live longer than men, so usually on the average. So that's why the rate of stroke is higher in women. Certain racial populations, African Americans and Hispanics, are 2 to 4 times more likely to have a stroke, have a more severe stroke, and to die from a stroke than the Caucasian population, and that's all genetics. So when we talk about stroke, we divide stroke into 2 categories. On the left here is what we call hemorrhagic stroke, and what that means is blood in the brain. How does that happen? A blood vessel ruptures, leading to 2 types of what we call hemorrhagic strokes. One on top, we call it intracerebral hemorrhage, means there's blood in the brain. This is just a CAT scan of blood in the brain. The second part is a subarachnoid hemorrhage. That is the type of blood that you get it looks like a star here because it's in the spaces of the brain, and that happens usually from a ruptured aneurysm. So hemorrhagic strokes, blood in the brain, ruptured blood vessels. The larger category of strokes, these are the strokes that we most often see. At least 83 to 85% of all the strokes that we see are going to be these types, which we call ischemic strokes. These are the strokes that occur from blockage of a blood vessel. So there's a clot in a blood vessel, no blood flow, and you have a stroke. These type of strokes we divide into 4 main categories. A big category here, which we call large artery atherothrombotic, which happens to be usually in the neck, these carotid arteries. You probably have heard of them. This is an example of a carotid artery with what we call a stenosis, a blockage here. The second category is small vessel, these teeny little tiny strokes. These occur from little microscopic vessels, the ones we just can't see, but they get blocked over time with people that have diabetes, high cholesterol, high blood pressure. A category here, which is embolic, I'm going to tell you a little bit more about that. That's a clot usually that comes from the heart. And a big category here, 30% of ischemic strokes, what we call cryptogenic. And what that means, like from the crypt, we actually don't know why they happen. So we do a whole bunch of tests, a whole big workup, and we never get to the bottom of it. We just don't know why the stroke occurred. Are you okay? You can see I'm not in your way? Yes? Okay. So what are the risk factors? Well, there are risk factors that we unfortunately cannot control. Age. As you get older, as I mentioned, you're more likely to have a stroke. Sex, as I mentioned, women have worse strokes and die more often from a stroke. Prior stroke. So once you have a stroke, your risk of having another stroke is increased. Family history or genetics. That's something we cannot change. However, there are lots of risk factors that we can change. Hypertension, very important risk factor for both ischemic and hemorrhagic stroke. Heart disease, so people that have clots that come from the heart, a condition we call atrial fibrillation, very common, especially in the elderly. If you take patients between the age of 80 and 89, the risk of having a stroke secondary to this condition called atrial fibrillation is over 20%. So very likely that their stroke happened from this atrial fibrillation. Cigarette smoking. So cigarette smoking causes many different bad things, but it narrows blood vessels and it causes inflammation. And that is why cigarette smoking is a very high risk factor for stroke. Transient ischemic attacks. These are basically exactly the same mechanism as an ischemic stroke, but what these are, people call them mini strokes. These are stroke symptoms that completely resolve. So for you to have a TIA, a classic TIA, that means that all your symptoms have to resolve within 24 hours. The reality is that usually TIAs resolve, 90% of them will resolve within that first 1 hour. But just because your symptoms resolve doesn't mean you should go to bed and say everything is okay. Your likelihood that you're going to have a real big stroke following your TIA is very high. So most people don't have TIAs warning them that, something is going to happen. I need to get care. I need to see what's going on. I need to go to the hospital. But the people that do have TIAs often feel like, I had this symptom, now I'm okay. Let me just, hang out and go to bed. And then they wake up with a stroke when it's too late to intervene. So anybody that has any stroke-like symptoms needs a full evaluation. We admit all our TIAs to the hospital for at least 24 hours to make sure there's nothing else that can predispose them to have a stroke. Diabetes, very high risk factor for stroke. Elevated blood lipids or cholesterol. Weight and sedentary lifestyle, which kind of fits into the whole circle of things of diabetes, high cholesterol, hypertension, lack of exercise. It all is linked together. So heart risk factors. I told you the heart is a big source of clots. The clots that go from the heart into the brain. The most common reason why a clot will come from the heart is atrial fibrillation. What atrial fibrillation is, it's when the heart is beating asynchronously. So not all the walls are moving. If all the walls are not moving in synchrony, they're kind of fluttering. Little pieces are moving at different rate. When that happens, clots form in the heart, and then the heart squeezes, takes the beat. The first place that a clot is going to go from the heart is going to be to the brain. That's the first vessels that come off of the heart. So although atrial fibrillation can cause clots in other parts of the body, the most frequent clot is going to go to the brain and give you a stroke. Other things, I'm going to show you some picture of all of this. Other things that can cause clots and things like that in the heart that can go up to the brain is sometimes people get like a tight valve or a stenosis. This happens to be someone with a mitral stenosis. Anytime the blood has to squeeze through a small opening, a small hole, anytime blood stops, it forms a clot. That's just what it does. It's the same thing as if you cut yourself and the blood starts going slower and slower, it clots. That's the normal process. So anytime blood is stagnated, anytime it has to go through a small opening, it can form a clot. So this is someone with a tight mitral valve, a clot forms here. This is somebody with a prosthetic valve, you know, when they have to fix the valve and they put a mechanical prosthetic valve, and then clots can form on top of it, and that's why people that have prosthetic or mechanical valves end up on blood thinners. They usually take Coumadin and things like that. This is somebody that had a heart attack, and now this piece of the heart is not moving, and a clot can form here and go to the brain. And this is somebody, just happens to be a rhythm of somebody with atrial fibrillation. This is an atypical stroke, but we actually do see that at Shands and not infrequently. This is infection. So not only can you get a clot that goes up to the brain, if you have an infection sitting on the valve, we often see it with people with drug use, IV drug users, because they inject all kinds of chemicals and often dirty needles, they can get infection in the heart, and that infectious embolus or infectious agent can actually go up to the brain and cause a stroke. So when we talk about brain, we say time is brain. And what does that mean? And you don't have to worry about these numbers, but each minute of a large blood vessel clot, you lose 2 million neurons. Neurons are brain cells. So each minute, you lose 2 million brain cells. And that is why it is so important, and that is why we count every single minute when a stroke person arrives, is because we lose so much brain tissue. Once a brain cell dies, as most of you know, it never comes back. Skin cells, hair cells, all of that stuff comes back. But once a brain cell dies, it dies forever. There's no way to regenerate. And this is why we're so aggressive when our stroke people come to our hospital, because we don't want to get that permanent damage that you cannot reverse. So in 1 minute, you lose 2 million nerve cells or neurons. In 1 hour, you lose 120 million nerve cells. You can imagine the damage that you have. And how do you translate that into the big perspective? Well, in 1 hour of a large vessel stroke, you age by 3.6 years. In a completed stroke, you age by 36 years. So you could take a young person that comes in and they're 20 years old, they have a stroke, and now their brain is 56. So very important. So what are the treatment options that we have for stroke? Well, this is the agent we call TPA, or normally known to the population as the clot buster. We call it, I don't know, people call it all different things. People call it the needle or the clot buster. And basically what this is a medication. It's a fluid that's delivered into your vein, and it goes from your vein into the artery and up into the brain, and it actually works and opens up the clot. If you think about it, like you pour that Drano down your sink, it's the same concept. It actually goes and finds the clot, and it's able to dissolve it. Yes, it sounds ideal, and it's a great drug, and it's FDA approved, but it's not as ideal in reality, and it doesn't always open clots, but this is the best thing we have. So for intravenous TPA, your time from symptom onset to time for you to getting the drug has to be 3 hours as per FDA. And what that means is from the time you have symptoms to the time that that drug is already in your vein cannot be more than 3 hours. The reason for that is because once you go outside of the 3-hour window, the risk of that drug and the risk being bleeding in the brain, because it's a very, very strong medication, overweighs the benefit of the drug. However, we as a stroke society, the American Heart and American Stroke Association, are using this drug to the 4.5-hour window because we believe that the safety definitely, and the benefit overweighs any risk. So as far as the American Heart, American Stroke Association, on a national level, not just in Florida, we use the drug up to 4.5 hours. But the FDA, formal FDA approval is only 3 hours. But if someone comes into us within 4.5, we will still administer the drug. So up until now, I'm going to talk about other treatments for acute stroke. The only FDA approved treatment for stroke is TPA. We're looking at other things. We're looking at things like hypothermia to protect the brain. There's a lot of controversy about that. So far we haven't seen if this treatment actually works. So let's talk about a case. This was a 42-year-old nurse. She actually was living in the Villages. She had no medical history except that she broke her right ankle about 5 weeks ago. Otherwise, she was completely neurologically, medically, completely normal. And she left the house. She had her crutches, and she was kind of jumping out, you know, holding up her foot. And she got into the car with her husband, and when her husband turned around and looked at her, he noticed that she had sudden slurring of speech. She was kind of hanging her head out the window, not responding to him, and only responding with these little slurred type of words. So what he did was he did the right thing. He did not drive her to the hospital, because driving to the hospital will get you there in a longer period of time than just calling the ambulance. Because once we get the call from an ambulance, we know what the patient has, we know the symptoms, and we wait for the patient in the emergency department. So you're much more likely to get treatment faster if you call the 911 instead of to have somebody drive you over. So he did call the ambulance, and the patient arrived in our emergency department within 90 minutes of symptom onset, so pretty fast. In the ER, she was very lethargic, and she had complete weakness on the left side. So she had very, very slurred speech, and her left arm and left leg had absolutely no function, zero movement. And we measure these kind of degrees by something called the NIHSS, which is just a stroke scale. Her stroke scale was 21, which on stroke scale purposes is a very, very high stroke scale. So this was a very, very bad stroke. So her CAT scan, and this is what happens. I'm sort of taking you through the process of actually happens when a stroke person arrives. So usually the first thing we're going to do is a CAT scan to make sure is there blood or no blood. Usually when you get someone in very early, you're not going to see anything on the CAT scan unless there's blood. Blood you're going to see right away. But if this is an ischemic stroke, you're actually not going to see anything on the CAT scan, and that is good. That is exactly what we want. Because if you already see damage on a CAT scan, that is damage that's irreversible. So when brain cells die, that's what you see on the CAT scan. So most of the time, if somebody comes in within that 4.5-hour window, the CAT scan is negative, and that's exactly what she had. Then the next thing we do is look at the vessels. This is called a CTA, or CT angiogram, because we want to see if there's a clot there. Based on her examination, it was clearly that she had a clot there, because this was a big stroke, and this was a big blood vessel. So if you look here, and you don't have to be an expert to read these scans, but if you look here, this is a normal, what we call middle cerebral artery. This is a big blood vessel. This is normal. This is the left side. On the right side, it doesn't go anywhere. It stops right here. So this is a blood vessel that supplies blood flow to the entire right side of the brain, entire thing, and it was gone, completely occluded. So because she came in within 90 minutes, she qualified for TPA, the clot buster. So she did receive the clot buster. However, we know from a clot that size that usually that type of clot buster cannot open up the vessel. We just know that from experience. So what are the other options? So now we have other tools in our toolkit available to get clots out in addition to TPA. Everybody that is in the TPA window, that 4.5-hour window, still deserves TPA. That is number one, that's FDA approved. A person has to receive the drug. But in a clot that we know will not open with TPA, we have these other tools available. So several tools. One device is called the Penumbra, another one is the Mercy, another one is the Solitaire, and they actually pull the clot out. I'll show you what it looks like in a minute. So when we think of reperfusion or getting blood flow to the brain, you think of the brain tissue as a fried egg appearance. And what that means is that the area directly that's supplied by the vessel, which is the yolk, that dies first, because when the clot is there, that area dies. But around that clot, which is the egg white, what we call the penumbra, is a big area here that's supplied by other little vessels sort of around there. So that area is still staying safe. So if we have someone that has, coordinating the microphone and I'm telling you, it's not easy, not an easy task. So So when we have someone that has a very small sort of egg yolk, small area that died, but a very, very large area that sort of needs that blood that is still surviving, that is someone that we want to open up that blood vessel, get that blood flow in, and rescue that tissue. Because the egg yolk, whatever's dead is dead. We can't help it. So the procedure that we do with the tools we have available is basically an angiogram. And what that is we put a catheter in the groin, in the femoral artery, up in here. We feed that catheter all the way through the body, up the aortic artery, up the aorta, and then from the aorta up these carotid arteries, and actually from there feed it further up into the brain. So the catheter goes all the way from the groin all the way up into the brain. You could imagine, not a very easy procedure. And when the catheter is at the edge inside the brain, we use the tools that can take the clot out. And this is what the tools look like. I hope you could see them kind of well. This is the first tool called the Mercy device, and it's basically shaped like a corkscrew. And what it does is goes into the clot. It punctures the clot. It attaches the clot, and then we open up a balloon and we suck the whole thing out. The Mercy device is very old now. We don't use it very often. I mean, in a cartoon picture, it sounds good, but it often is not so good at getting clots out. But it's still a device that we use as a rescue when we can't get all the other tools up there for whatever reason. Sometimes we do revert to the Mercy. The next device, this was approved in 2009, is called the Penumbra device. And this is a device that has a little suction catheter at the end. So when the catheter is all the way up into the brain, we push this suction in there, and it actually suctions the clot like a little vacuum in little pieces until there is no more clot. This device is also now archaic because we're coming up with these devices all the time, newer and better clot retrieval and better outcomes. So this was approved in 2009, and already it's kind of phasing out. The latest devices, and these are the best, this is the best, this is a whole new era, are these devices they call them stent retrievers. This one is called Solitaire, which is the most frequent one we use. And basically what these are, there's a stent. So you heard of people putting stents and stuff like that in the heart, or people getting stents in their vessels for peripheral vascular disease. So this is a different type of stent. It looks very similar to the other stents, but this is a stent that doesn't stay. So this is a stent that goes in, it captures the clot inside of the stent, and then the whole stent collapses down into the balloon, and we remove everything sort of out of the body in one piece. So this, getting back to our patient, this was our patient. This was her post-TPA, the clot buster. And this is what her artery looked like. If you look here, there's supposed to be a very large artery coming out of here that sort of supplies the rest of the brain here. It's gone. So the TPA did absolutely nothing for this young woman. So we had to use a device, and the device we chose at the time was the Penumbra device, because that was right before the stent retrievers were available. So we used the Penumbra device after she got the intravenous TPA, and you could see now this artery, you see this artery that was gone? Now it's completely wide open, and it's gorgeous, and it provided all the blood flow she needed. And this was her MRI. She did wind up having, remember I told you about the fried egg? Well, this was her fried egg. So this was the area, the yolk that had died that we could not rescue no matter how much blood flow we restored. But the area supplied by that vessel would have been this entire hemisphere. So we saved this whole part of her brain, and she only wound up having with a very, very small, very deep stroke that really did not affect her very much. So on day 2, she was walking, she was talking, and we were able to discharge her home. She didn't even need rehab. She went home, and now she doesn't even see me anymore, the nerve of her. So she's doing so well, so she doesn't come to neurology anymore. She works in the cath lab, and she's doing great. So she's able to take care of her little kids. So when you come to the hospital, initially we make the decision, do we treat with TPA? Do we treat with one of these other devices? Then after we treat the person in the acute stage, we have to look for the cause of stroke. And this is, once you're hospitalized, these are the studies that are going to be done. We look at the carotid arteries. We do something called a carotid Doppler or an ultrasound. So we look at the carotids to see if there's a clot in the carotids that could have caused a stroke. We look at the heart. Remember, the heart is very important to see if there's any clots in the heart, to see if there's any atrial fibrillation. We do something called an echocardiogram, which is basically an ultrasound of the heart to see, look at the valves, see if there's a problem with the valves, to see if there's a clot anywhere, to see if somebody has had a heart attack in the past that can cause a clot to form. We sometimes do an MRI, often we do an MRI, and something called an MRA, which is an MR angiogram. It's the same thing as an MRI, but looking at the vessels. Just like before I showed you a CT and a CTA, this is the same analogy. So this is an MRI and an MRA looking at the vessels. Now, if we already did a CTA, we looked at the vessels before, then we usually do not do an MRA. But often we do an MRI. An MRI gives you a much better picture of the brain than a CAT scan. So a CAT scan happens very fast. Oh my gosh, I'm very not good at this. Sorry about that. So the CAT scan we prefer in the immediate stage because the CAT scan takes 1 to 2 minutes to do. An MRI takes about 45 minutes. So you could imagine if you're trying to save brain, you cannot send someone to the MRI scanner. So as a screening tool, the CT is the best. But when we want to look at other things, other strokes, other more things in detail, then we do an MRI. So, and then we do blood tests. So we look for things like diabetes. We check the hemoglobin A1C, which is a test for diabetes. We check the lipids or cholesterol. We see if the cholesterol could have been a problem. And in people, the younger population especially, when they can have those weird kind of strokes, then we do more extensive tests looking for genetics, looking for any kind of clotting or anything like that that they can have in their blood or in their system. If we do find that somebody has a thrombus, a cholesterol plaque in their carotid artery, we do a procedure called a carotid endarterectomy. And that is when we cut the artery. In this picture, you could see this is a cartoon version. We actually cut the artery, clean it out, and then close it back up. And this is an endarterectomy. Another way to clean out the cholesterol plaque is something that's called a carotid stent. So just like you could put a stent in the heart, this is not the stent we use to get the clots out. This is a permanent stent. So once you put this in, you don't collapse it down and take it out. This is a stent that always stays. So we could put in a stent. This is a cholesterol plaque compressing the artery here. You see how it's very, very thin. And this is a stent that kind of like an umbrella goes through and just pops the cholesterol plaque open, and you could see that the cholesterol is kind of on the walls of the vessel. So then the vessel is completely open on the inside. The next thing we do is after we figure out, what caused the stroke, was we put people on medications. Most of the time, unless we find a clot somewhere, we treat people with what we call antiplatelets or antithrombotics. The 3 medications that we use are aspirin, Plavix, or Agranox. Have you heard of these? I'm sure you have, right? They've been around a long time. How do we make a decision between those 3? It's very complicated, and sometimes it's a very difficult decision and a very individualized decision. But often aspirin will suffice. And someone has a plain stroke that's the first time stroke that doesn't have clots anywhere that we can find, then often we just use aspirin. And aspirin is a great drug, and often people feel it's a vitamin, but it's not. It's actually a very good secondary stroke prevention medication. If we do find that somebody has a clot, or they have atrial fibrillation, or they have a mechanical valve or something like that in the heart, then we put them on stronger blood thinners. The stronger blood thinners, usually we use heparin, which is in the IV, which is just in the hospital. But when they're discharged, we send them on one of these drugs, either warfarin or Coumadin. That's an old drug. It's over 60 years in use, so you probably have heard of it. The newer blood thinners are dabigatran or Pradaxa, Viroxaban or Xarelto, that's the brand name, or Apixaban or Eliquis. That's sort of the brand name that people know of. And that's only if we find a clot somewhere that we feel that these type of medications are warranted. And of course, secondary risk modification, huge and very, very important. So we manage diabetes. We want the A1C, the measurement of diabetes, to be less than 7. Aggressive cholesterol management, we want the LDL, which is your bad cholesterol, to be less than 100. If you have diabetes, we actually want that bad LDL cholesterol to be less than 70. We usually start people on a drug called the statin, which is a cholesterol medicine. The most common ones you've heard of is usually Zocor, Lipitor. These are probably the ones you've heard of. So everyone with a stroke, regardless of their cholesterol, goes on a statin medication. And the reason for that is, in addition to the fact that it lowers cholesterol, this is an anti-inflammatory medication. So it actually causes decreased inflammation in the areas of the brain or in the vessels of the brain. And that is why everyone with a stroke, regardless of cholesterol, will still go on a cholesterol medication, one of the statin drugs. Aggressive blood pressure control, we want a target of 120/80. That's a normal blood pressure. We want people to have that normal blood pressure. Sometimes when people come in and their blood pressure is very high, we do not drop it immediately, because what will happen is when you have a stroke, your brain actually sends a signal to the rest of your body, hey, I need the blood flow, increase the blood pressure. So the blood pressure when you come in with a stroke is usually falsely elevated just because the brain is telling your body to do so. So if we, in the acute setting, drop the blood pressure with medication, when a person 2 weeks out goes back to their baseline, we're going to bottom them out, and they're going to have very low blood pressure, and then they have all kinds of symptoms from that. So when someone comes in that acute setting, we get the blood pressure down, but not very aggressively. And then over the next few months, we work at a target of 120/80, with the patient, depending on what disease they have. Smoking cessation and alcohol in moderation. And what that means is, with alcohol, it's sort of what we call a J-shaped curve. And what that is for women, 1 drink a day is supposed to be therapeutic. It actually decreases your risk of stroke. They're laughing. 2 drinks per day for men. However, once you exceed that number, then your risk of stroke increases. So a little bit of alcohol is actually good for you, but too much is actually not. And it causes both ischemic and hemorrhagic strokes. So it is very important that if somebody is having a stroke, that they're delivered, and delivering of a person is very important, to the appropriate, what we call a stroke-ready hospital, a hospital that can manage stroke. Because if they go to a hospital that can't or doesn't have appropriate devices to manage stroke, then you can imagine a lot of time is going to be lost through the transfer. So the main designations, the 2 main designations for hospitals are primary stroke center, and this is like North Florida Regional. There's a whole bunch of hospitals in Ocala. I mean, I forgot, what was the number again? How many there are in the U.S.? How many? Okay, so 97 primary stroke centers in Florida. So these are good hospitals. These are hospitals that can manage stroke, but they can't manage complex stroke. So if you need someone that has a complex stroke, if you need someone that needs any of those tools, any of those devices to get the clot out, then you have to go to what we call a comprehensive center. And right now there's only 3 in the state of Florida. It's Shands Baptist in Miami, and Mayo Jacksonville. So those are the only 3 that are here. So to be a comprehensive center, it's a very rigorous evaluation. You have to prove that you have a lot of coverage, a lot of things. You have to have a specialized ICU, and you have to be able to deliver 24/7 care, regardless of whether it's surgical care or intravenous TPA. So there's a lot more characteristics that you have to be a comprehensive center. Another way that we treat stroke people in areas that are maybe more rural, if they don't have access to either a primary or a comprehensive center, we use a system called a telestroke. And that is, so a person comes in, say they're at a smaller hospital, a rural hospital, via a computer monitor, via a telemonitor, a doctor can evaluate the patient. We can examine the patient via the monitor. We could start the TPA. We call this the drip and ship. We could start the TPA, and then we could ship them to our hospital while the TPA is still running, and then administer those devices if needed. I mean, if we give the TPA and we bring someone and we do that angiogram and we look at the blood vessel and everything is open and pretty, then we don't use the devices. We only use the devices if the clot is still there, if the TPA didn't work, if the person is not better. So we only use them emergently, obviously. as necessary, obviously. So when we treat stroke in what we call this is the golden hour. And what that means is when the person arrives in the emergency department, whether it's a primary or a comprehensive center, they have to receive the drug within an hour. This was the old recommendation. Now the recommendation is to get the drug within 45 minutes. We feel like an hour is really long. But if you think about it, you know, to you sitting there, 45 minutes, my gosh, how many brain cells are you going to lose by the time you deliver the drug? But a lot of things have to happen before that drug is delivered. Number one, they have to be evaluated, so they have to be examined by the stroke team very quickly. Number two, they have to have a CAT scan because we got to make sure, blood or no blood. So they got to get to the CAT scan, the machine has to do the study, then we have to look at the study. We have to have special IV lines to be able to deliver the drug. We have to draw blood. So if you take somebody that's maybe on a blood thinner, and the blood is so thin that if we take this TPA drug and we give them a TPA on top of their blood thinner, they can bleed to death. So we usually have to check blood. We have to make sure that they're not on a blood thinner. We have to make sure that their blood counts are okay. You know, somebody that comes in with anemia, somebody's blood count is very, very low. We don't want to give them a drug and drop their blood counts even further because that's a bad thing. So we got to draw their blood, we got to do the CAT scan, we got to look at the CAT scan, we got to get the proper IVs in, and then we got to mix the drug. The drug comes in the powder, we have to mix it, we have to set the machine and hang it, and that's why, you know, you lose a lot of time that way, obviously. But we have to be a primary or comprehensive center, we have to deliver the drug within 60 minutes and preferably now within 45. So because we have to deliver all these treatments very quickly. University of Florida, we have many transfer agreements with all these hospitals across the state of Florida to get people over, to get them here faster, you know, so we don't waste any time. And these are all the hospitals that we have transfer agreements with. And this is our stroke team. We have the helicopter we can send out. And I'll take any questions. I thought I'd have more sort of throughout the lecture, but now we have a few more minutes, I guess, for questions.